Good evening, and welcome to today's panel conversation on racial disparities in health and wellness policies. For those of you who've not attended one of the earlier panels, my name is Michael Deli Carpini. I'm a faculty member and former dean of the Annenberg School for Communication at the University of Pennsylvania and faculty director of the SNF Padilla program at Penn, whose mission is to facilitate robust, informed, and respectful dialogue on the many difficult, contentious issues facing the nation and the globe, and across the many ideological, cultural, and demographic divides that too often keep us from effectively addressing these issues. This panel is the fifth of 13 we are holding over the course of this academic year as part of the preceptorial, which is essentially a non-credit bearing course on racism and anti-racism in contemporary America. The preceptorial is designed for Penn undergrads, but each panel is open to the entire Penn community and to the larger public. I'm pleased to say that we have well over 200 people registered for today's event. The preceptorial is sponsored by the SNF Padilla program at Penn and co-sponsored by a number of other important Penn centers and offices, including the Office of the Vice President for Social Equity and Community, the Office of the Provost, the Andrea Mitchell Center, Civic House, and new student orientation and academic initiatives, all as part of the Year of Civic Engagement at Penn. Now, while inspired by events such as the murder of George Floyd and the resulting protests, demonstrations, and calls for change that emerged from them, this series of panel discussions is designed to explore the ways in which racism has long been embedded in our country's economic, housing, public health, criminal justice, education, cultural, media, and political systems, to better understand the root causes of this structural racism, and to identify what we have or might do to address these inequities. Today's panel is the second of two that focus on the impact of racism on the physical and psychological health of African Americans. I should note to the audience that you can use the Q&A function on your screens to ask questions. While we won't be able to answer all of them directly, I'll leave time towards the end of today's panel for me to ask our panelists some of them on your behalf. We have another stellar panel to address today's issues and your questions, while we'll now very briefly introduce. So I'd ask the panelists to please unmute your videos now so the audience can see you. Thank you. The first is Benoit Dubé, Associate Provost and Chief Wellness Officer and Associate Professor of Clinical Psychiatry at the Perelman School of Medicine at the University of Pennsylvania. Dr. Dubé began his career at Penn in 1997 as a resident and then chief resident in psychiatry. He served as the Director of Medical Student Education in Psychiatry, was appointed as an Assistant Dean for Diversity and Inclusion, was chosen as the school's first Director of Wellness Initiatives. Now, as Associate Provost and Chief Wellness Officer at the university, Dr. Dubé directs wellness initiatives across Penn and oversees an integrated new health and wellness division that includes alcohol and other drug program initiatives, campus health counseling and psychological services, and the student health service. The Wellness at Penn initiative, which Dr. Dubé leads, affirms wellness as a central priority of campus life. Our second panelist is Zeke Emanuel, the Diane S. Levy and Robert M. Levy University Professor and Vice Provost for Global Initiatives at the University of Pennsylvania. He's also a special advisor to the Director General of the World Health Organization, as well as a senior fellow at the Center for American Progress. Dr. Emanuel was the founding chair of the Department of Bioethics at the National Institutes of Health and held that position until August 2011. Until January 2011, he also served as a special advisor on health policy to the Director of Office of Management and Budget and National Economic Council in the Obama administration. I'll mention that among his many publications is the book, and I'm going to say this because I just love the title, Reinventing American Healthcare: How the Affordable Care Act Will Improve Our Terribly Complex, Blatantly Unjust, Outrageously Expensive, Grossly Inefficient, Error-Prone System. So I'm sure he has a lot to say about that in the following conversation. He's a member of the Council of Foreign Relations. He has received numerous awards, including election to the Institute of Medicine of the National Academy of Science, and he's a frequent guest expert on MSNBC, and now a member of President Biden's COVID task force. Next is Risa Lavizzo-Mourey, the Robert Wood Johnson Foundation PIK Professor of Health Policy and Health Equity, with joint faculty appointments in Penn's Department of Medical Ethics and Health Policy, in the Perelman School of Medicine, the Department of Healthcare Management in the Wharton School, and the Department of Family and Community Health in the School of Nursing. Dr. Lavizzo-Mourey is a world-renowned expert in health policy and geriatric medicine, having served as president and chief executive officer of the Robert Wood Johnson Foundation. She's been named 8 times to the Forbes list of the world's 100 most powerful women, and 9 times by Modern Healthcare as one of the 100 most influential people in healthcare. She's published over 100 original articles, editorials, and book chapters, appearing in the most influential journals in her field. I should note that Dr. Lavizzo-Mourey needs to leave a bit early tonight to attend yet another Zoom meeting, but we're happy to have her here for most of the first hour of the panel. Our fourth panelist is Jennifer Prah Ruger, the Amartya Sen Professor of Health Equity, Economics, and Policy in Penn School of Social Policy and Practice. Dr. Prah Ruger is a leading scholar of global and domestic health policy and public health. She conducts theoretical and empirical studies of health equity to address global and national health inequities, especially among women and children. She directs the Health Equity Policy Lab, a mixed methods lab that studies health policy and public health problems. Her research has been conducted internationally and nationally in a number of countries across the globe. And among her many publications is the book Health and Social Justice, published by Oxford University Press. Dr. Prah Ruger was recently named a Hastings Center Fellow for her work in deepening public understanding of complex ethical issues in health, healthcare, science, and technology. And last but certainly not least is Eugenia South, Assistant Professor of Emergency Medicine at the Perelman School of Medicine at Penn and Faculty Director of the Penn Urban Health Lab. As a physician scientist, her broad vision is to improve health and quality of life for residents in low resource and Black communities through both research and clinical work. Dr. South's research agenda focused on developing and testing individual and neighborhood level interventions to better understand the ways in which physical and social attributes of where people live, work, and play influence physical and mental health and community safety. Her work on vacant lot greening has been published in JAMA, NECMA Open, PNAS, and AJPH, and has appeared in national, international media outlets such as the Washington Post, NPR, and Time magazines. So thank you all very much for being here. I'm really excited to hear what you have to say about today's topic. And while today's panel is focused on health and wellness policies, and future panels in this series will focus explicitly on the political system, I would like to give the panelists a chance to reflect on recent events, in particular, but not necessarily limited to, the recent elections and the problematic transition in government, all of which will have major implications for issues of race, as well as issues of health and wellness in the United States. So Zeke, since you've had a lot of experience in both the Obama and now the Biden administrations, I'd like to start with you and just get any thoughts you have on the recent election and its aftermath, the role race may have played in it, and the election's outcomes and implications for issues of race and racism in the U.S. going forward, though of course you can address any other recent event that you might like. So Zeke, would you start us off?
That would take a very long time, but let me just focus on one thing that I think President Biden has done, and that is to appoint Marcella Nunez-Smith to head up an equity task force and come back with recommendations on how to make equity considerations pervasive through the government and especially in the healthcare sector. I think this is a major turning point. Just like the environment got infused in all sorts of considerations, cost-benefit analysis got infused in all sorts of considerations, I think equity is going to become pivotal. You're going to see it in the mundane. Grants are going to have a section on how you're addressing equity. You're going to see it in the profound. Regular assessments of how we're doing on scales of equity in major projects that are launched by the government, whether by Medicare, Medicaid? How are they actually addressing and narrowing the disparity in all sorts of outcomes, heart disease outcomes, life expectancy, cancer outcomes? And so I think this, and Marcel and I have talked in detail about how to make her task force most effective, not to produce a report that gathers dust, but to actually change government behavior and how to make it very visible to people on a regular basis. I think this is going to be a major shift that President Biden has launched, and will be one of his longstanding legacies, frankly.
Well,
just like everyone refers to Richard Nixon and the Environmental Protection Agency, I think this has the power, the capacity to be quite similar.
That's a great observation. It's something I had not thought about. Risa, anything you'd like to comment on in terms of recent events?
Well, I'll stay on that same theme because I know that during the transition time, the task forces and groups that President Biden pulled together really focused on health equity. And now as we are seeing some of the policies coming out, most recently the recovery plan for addressing COVID and beyond, we're seeing that these plans are implementing that. They not only direct our attention and the resources to making sure that people get the care that they need, but also to looking at the social determinants of health. We know that things like education and housing and transportation, access to decent employment and so on have a huge impact on the racial divide and equity. And he's gone even further than saying we have to address these things to putting actual language in that says, we've got to measure it and make sure that we're actually closing those equity gaps. So I think that it's a time to be optimistic and to put our shoulders to the wheel.
That's great. That's great. Yeah, we were talking earlier about how feeling hopeful is a strange feeling these days, but it's a comforting feeling. Jennifer, what would you like to add?
Thank you. Well, I'd like to agree with what Zeke and Risa just said, and expanding and maybe sort of going deeper in terms of health equity. And what's on my mind is whether the new administration can really restore and maintain trust of the American people and in their government, and at least in the first case in handling the COVID epidemic. It's clear that a federal response is required, that we need the federal government to take the lead, as has been done in other countries. And they've advanced things in a more expeditious and equitable manner than we have in this country. And that trust is related to relying on experts, and experts that people trust. The president needs these experts to be focused on solving the problems that need to be solved as they unfold, literally at a minute's notice. And these experts have research experience, they have policy experience, they have practical experience. And so in a democracy, we need to trust our government and the people that surround our leaders, that they will take the measures that are necessary to protect the people. I'm also interested in how far the government can use this executive power, and where the boundary is going to be in a new administration. Naturally, people are going to be concerned that the use of executive power and the use of this force and expertise is going to cause a great deal of changes. And so I'm wondering where the limit is going to be, where the boundary is. And then finally, I'm wondering how the new administration is going to also restore accountability. And will the government be able to handle this pandemic well for all Americans? Will it hold itself accountable? And if that occurs, we'll also get back to what my first issue is, which is people will give it more trust. They'll be more trustful in the government, and they'll allow it to then use its power on behalf of them more equitably and expeditiously.
That's great. Excellent point. Thank you for bringing up the issue of trust, which I think is going to be really complicated and crucial. Gina, what would you like to add?
Yeah, something that's weighing heavily on my mind that relates to everything that's being talked about is COVID vaccine distribution. Give me 1 second to get my video back on here. It froze at an inopportune time.
We can hear you though, so.
Okay, well, I'm gonna just keep talking, even though you can't see. So, there has been an inequitable distribution so far of the COVID-19 vaccine. Data from the Kaiser Family Foundation shows that in Pennsylvania, for example, white people make up 81% of the population in Pennsylvania, but have gotten 91% of the vaccine. Black people make up 12% of the population, but have gotten just 3% of the vaccine. When we look to see what's happening within our own institution, within Penn Medicine, where we actually have more control over the distribution of the vaccine, we see a striking disparity amongst our own employees. So in the first month of vaccine administration, approximately 70% of the white employees who were eligible to get the vaccine got the vaccine, and only 30% of the Black employees who were eligible to get the vaccine got the vaccine. Those are sort of approximate numbers. This is alarming. This is incredibly alarming that the communities and people who are hardest hit by COVID are right now, we're seeing in real time, the ones who are least likely to be getting vaccinated. And so, first, I think as an institution at Penn, we have to really understand that the impact of racism on our lives, on the lives of our employees and our trainees and our students is something that's very real inside of our walls. It's not something that's happening outside that doesn't, there's some like wall between us. No, it's happening inside of our own institutions. And this is just a great manifestation of that experience of racism and how that sort of patterns people's decision-making. I think another thing when we think about, what is the root cause of this disparity, I think it's multifactorial, but it goes back to what Dr. Ruger was talking about as far as trust and particularly medical mistrust. There are certainly historical components to that, but I think it's actually more important to focus on the present day components of medical mistrust and why people's experience today within medicine, but also within all the other systems that they interact with, from birth, education, criminal justice, housing. People's experience in those systems has engendered the mistrust that we are seeing manifest in this disparity of COVID vaccine uptake. And I think it's really important for institutions to acknowledge and recognize the ways that they continue to perpetuate racism and disparities as the first step towards then, addressing all of those various disparities. And so, I think there is an urgent need to build trust with the Black community, both from Penn Medicine, from Penn as an institution, but all institutions. This is not a Penn problem. This is sort of an institutional problem. And that really has to do with what are the policies we are going to enact and how are we going to enact them.
That's great. And you, first of all, thank you for bringing it home to Penn a little bit, but also you raise a number of issues that I think we'll return to when we get to the next set of questions. But first, I want to see if Benoit has anything he'd like to add from either perch that you sit in at Penn or more broadly.
So the first thing I'd like to comment on is just to reflect on what we just heard from Dr. South. And it really highlights how it's really important to highlight the importance of having a trauma-informed lens when we deal with patients, clients, students. And what that means very practically and how we can apply this in our daily lives, everyone, is to get rid of what's wrong with you as an initial reaction and replace it with what happened to you. So when someone says, I'm going to wait for the vaccine, or I don't want the vaccine, many of us would think, well, what's wrong with you? Why don't you want a vaccine? Like there's people who are clamoring to get the vaccine, but rather switch our mindset and ask ourselves a question. So what happened to you that would make you not want to access the vaccine? And we need to think long and hard about that and accept all the answers, because there's no wrong answers. There's many reasons why people are distrustful. And that goes back to what Jennifer was saying about trust, the importance of trust. Trust has been broken in the department. We've had an alcoholic parent that has dominated the news for 5 years, right? A parent who was mercurial, unpredictable, but also at times charming and mesmerizing. And we've been under this spell And now we can breathe a sigh of relief because of all the hopeful things we've heard from my colleagues on this panel. But we have many tasks at hand if we want to repair that trust, as we can breathe a sigh of relief. And then we have more work to do and to tackle these inequities, both at the policy level, but also in our daily lives as well, by affording ourselves, giving ourselves permission to engage in difficult conversations at times, because we need to, because there's urgency.
That's great. That's great. Thank you all for that. It really sets the stage well for a little deeper dive now. One of the things I try to do in these various panels is paint people a portrait of the issue that we're dealing with and what those disparities look like, because I'm constantly amazed at how little people sometimes know, to be blunt, especially the majority population, whites, on what these disparities look like. So what I'd like to do is to ask each of you to talk a little bit about how mental and physical health disparities manifest themselves. You've started to do that, both in statistical aggregate terms, in terms of numbers, but also the lived experiences of African Americans. And so we did a little bit of that at our last panel, but there's plenty of room to talk more about that. And again, for those of you who are directly involved in developing and implementing Penn's health and wellness policies, I'd be particularly interested in the way in which race-based disparities manifest themselves among the community of Penn students, faculty, and staff, but also more nationally. So for this one, let's just start with Risa, if you don't mind. Risa, could you give us a sense of the ways health and wellness differ at Penn, in Philadelphia, or nationally by race? Are these differences shrinking or growing? Do they vary by particular locale? Just help us get a picture of the problem, if you will, that this panel is attempting to uncover and address.
So I'm going to stick with the theme of how the social determinants, the factors that influence where we, as Gina said, live, learn, work, and play, make it either easier or harder for people to be healthy and to have a lifestyle that allows them to meet their optimal health. And let me just paint a picture for you of what a person living in Philadelphia might experience versus, and we know that Philadelphia is majority Black and brown. I could break this down by particular zip code, but I'm going to keep it at the county level and compare that to Montgomery County, where, the main line and where a lot of faculty and others live, that is predominantly white. So if you live in Philadelphia County, life expectancy is 76 years. High school graduation rates are about 79%. Now you need to compare that to Pennsylvania overall, which is 87%. And in the highest performing areas, it's 96% graduation rate. If you look at the child poverty rate, it's 34%. And compare that to an overall rate of 17% in Pennsylvania as a whole. If you look at social associations, the social connectedness of many of our communities, and measure that by the number of social associations per 10,000 population, it's 7.6 in the neighborhoods in many of Philadelphia compared to 12 for Pennsylvania overall. And if you look at income inequity in these neighborhoods, using one measure that looks at what is the ratio of people of the top 80% to the bottom 20%, in Philadelphia, the percentile is 6.4 compared to 4.8 overall in Pennsylvania. And then this one I like because it looks at commute time. What percentage of people have a long commute, more than an hour commute a day? And it's 54% in the Black neighborhoods of Philadelphia as compared to 34% in other parts of Pennsylvania. Now, let me just tell you how that compares to Montgomery County. Life expectancy 4 years longer, 80 years. Graduation rate, 87%. Child poverty rate, 7% compared to 33%. number of social associations near the top of the range, and long commute, 45%. Now, by the way, if you look at the death rates from COVID, between January 1st and January 25th, it was 12.5 in Montgomery County per 100,000 population. And in Philadelphia, it was twice that. So these social factors that make it either relatively easy to have a healthy lifestyle, getting the education you need, having access to employment that pays a living wage, having access to green space and short transportation times. These are the things that, in addition to the access to healthcare, make such a huge difference in the disparities that we see in race.
Those are stunning statistics, at least for some of us, but necessary for people to know. Jennifer, COVID is obviously on everyone's mind and is a really blunt example of some of these racial disparities, but it's not the only thing. Could you talk a little bit about health and wellness disparities by race and what we know about them and how they manifest themselves?
Yeah, thank you. I wanted to talk a little bit about at the federal level, some of the health and wellness policies that we have in the United States and how variable and ad hoc they are, and how disparate they are by racial and ethnic groups, as well as by income, and by where we work, as well as where we live. So we have health and wellness policies actually that are mandated at the federal level in terms of federal agencies. And these are integrating prevention strategies into the workplace. And this follows the idea that the worksite health and wellness programs can actually aid employees in their attempts to be healthy, change their lifestyle, seek optimal health that Risa was just talking about. And also the reason or one of the rationales for it is that it actually helps the organization in terms of increasing productivity and employee engagement increases, helping employee recruitment and retention and these kinds of efforts to make it a more productive workplace. And so what we see is we have a lot of health and wellness programs across these federal agencies, and they're focused on health education, nutrition, physical activity, the sort of screening, vaccinations, disease management, all these kinds of efforts. But these programs are focused on a federal workforce that's very disproportionate. So we have about 2 million civilian workers in the US, and Black employees represent about 18% of the permanent federal workforce, whereas white employees represent roughly 65% of the permanent federal workforce. So there we see efforts that we actually have in federal agencies that are focused on health and wellness, and they're supported to do so. And yet we have a very disproportionate set of protections in place for health promotion and wellness measures. So the other thing I wanted to say is that in actually all sectors of our economy, an American Journal of Health Promotion study found that half of workplaces, and these are for-profit, non-for-profit, and government, actually offer health and wellness programs. And so that's terrific, and that's a great thing, but there's a huge variation by the size of the employer. So when you look at employer size, about 39% of work sites with 10 to 25 employees, and 39% of work sites that have 39% have health and wellness programs. Of work sites with 99 employees, 60% of them have health and wellness programs. But with the companies, the entities that have 500 or more employees, 90% of them have health and wellness programs. And then when you look again at how people are working in different environments, we see that, for example, 99% of minority-owned businesses are small businesses. We see that Black-owned employer firms had the largest share of female owners. And we also found that the number of working Black business owners fell by about 40%, and far more than other groups during the COVID-19 epidemic. So what we see here is when we look at health and wellness policies across the nation and the workplace, that they're covering a very different set of people in very different settings and have obviously a disparate impact.
Those are really informative statistics, and I like that you're pointing out that when we talk about health policies, we're talking about government health policies, but we're also talking about institutional health policies, including at a place like Penn. Gina, what would you like to add in terms of the painting us a picture of the extent of these kind of disparities?
Yeah, I want to build on what Risa spoke about and really talk about neighborhoods, which is a lot of what I think about. I have this problem every time I come off mute my video.
Well, we can hear you still though. So.
Okay. To talk about neighborhoods. So to think about the mortality gap actually within Philadelphia. So there's actually, depending on where you live in Philly, up to a 20-year difference in life expectancy between Society Hill and let's say Strawberry Mansion. So that's pretty striking. And when you think about neighborhood conditions, so both the physical conditions of neighborhoods like tree canopy and park access, housing quality, food resources, and also the social conditions, so thinking about crime and social connections, those are so foundational to health and that mortality gap. And so we really need to address the conditions in neighborhoods if we want to move the needle on those big outcomes like mortality gap. The first study that I did when I came to Penn over 10 years ago was to ask people in West Philadelphia what they thought the impact of their neighborhood environment was on their health. And people really talked a lot about the impact on community health and the connections that people were able to forge with each other, and how the deteriorating physical conditions actually impacted how people were able to relate to each other. And they also talked a lot about mental health, that they experienced stigma from living on a street that had a lot of vacant lots or abandoned houses. So we know that these conditions impact health. And so when we talk about health and wellness policy, we really have to include policies that dictate the conditions of neighborhoods and also that dictate where people get to live. We can't talk about neighborhoods and neighborhood conditions without talking about residential segregation, which is the hallmark of the American neighborhood. And that is because of racist, federal, state, and local policies like redlining and the way public housing has been implemented, as well as things like discriminatory lending practices, which is ongoing. That's an ongoing problem that, as Dr. Prah talked about, with the differential loss in small businesses affecting the Black community, that in large part has to do with access to capital, access to wealth, which is dictated by a lot of things, but by banking policy. And so, the result of all of this is that we have seen decades of disinvestment in Black neighborhoods, which has led to the spiral of physical decline that impacts health. And so, there are things, though, that we know that can make a difference. And I'll give you a few examples in Philadelphia of, simple, structural, and relatively low-cost place-based interventions that have been shown and proven to have an impact on health and safety. One example is vacant lot greening. So Philadelphia has 40,000, vacant lots that are blighted and vacant spaces. And when you turn those spaces into clean and green spaces, you have improvements in mental health for people living nearby. So again, that connection between the neighborhood environment and mental health. You have reductions in crime. You have people reporting stronger social connections. So it's actually a range of outcomes that this very simple intervention impacts. Abandoned house remediation. So fixing up abandoned houses has been shown to lead to a drop in crime. And then there's a program that the city does called the Basic Systems Repair Program, where they provide grants for structural improvements to homes that are owned by low-income families. And we're just finishing up a study on that that's showing that investment into the structure of neighborhoods is actually leading to a drop in crime. And so again, we need structural investments, and that's a policy. We have to decide how are we going to spend our money and where are we going to put our money and resources and to do what. And I think coming from a federal, state, and local level, from government, but also payers. Why shouldn't payers be thinking about investing in the structural aspect of neighborhoods, because it's going to have an impact on health systems, who also can think about putting money and resources into these things. All of it's really vital.
Again, excellent points. I mean, some of those points point to the kind of limitations of the way these series of panels are structured, because we had a panel earlier in the fall on housing policy, on economic inequality, another panel, but clearly all these factors are so intertwined that it's difficult to structure them just around the individual topics. So thank you for that. Benoit, what would you like to bring into this discussion?
I think that what Gina is sharing is practical ways that we can enhance community. And some of it relies on the individual, but much of it actually depends on policy and programming and funds and grants that can be offered to embellish neighborhood. If you're proud of where you live, if you feel safe where you live, you're more likely to talk to your neighbors. And it brings up the issue of a social safety net that is often lacking, that can be built and woven very skillfully by very simple policies, such as the ones that Gina outlined for us. There can be policies at the neighborhood level, at the county level, state, or as at the federal level. And it's important to acknowledge these things and make choices about what's important and what we want to prioritize.
Yes, agreed. Zeke.
So I just want to throw out two statistics to begin with. One is on the COVID situation. And I do think, the disparities on COVID are pretty substantial. Just to put it in context, if you look at hospitalizations, African Americans and Hispanics are 3.5 to 4 times more likely to be hospitalized than white patients, and about 2.8 times more likely to die as a result of COVID. So pretty enormous disparity. Risa and I wrote a paper for The Atlantic, and one of the statistics we had in there, I think, just summarizes how bad the health disparity is in this country. And that is the average. Gina was giving us the sort of Philadelphia, the two extreme zip code life expectancies. But if you look at the average across the country between blacks and whites, blacks live 3.6 years less than whites do on average across both races. Now, that might not sound like a lot to people who aren't used to those data. And so to put it in context, one of the things that Risa and I did was to say, if you cured every cancer in the country, I'm an oncologist, so I think about everything in relation to cancer. You cured all the people suffering from cancer in the country, that would add to the average life expectancy fewer years than the disparity between whites and blacks.
Wow. So
it's just enormous when you talk about the population of the United States, how big that disparity is. And that goes to everything everyone has been talking about. It's not just the disparity in healthcare and access to doctors and hospitals and other healthcare services. It's, as Risa pointed out, the disparity in housing, the disparity in food, the disparity in education, the disparity in transportation. All of those things factor into those differences in life expectancy. And truth be told, healthcare services, what we get from the hospital and doctor, are a small fraction of that disparity. Much bigger fraction are all these other elements of everyday life. One of the advantages or disadvantages of working at the Office of Management and Budget is just the crazy quilt social support system we have. Between earned income tax credit and food stamps and WIC and the housing programs and minimum wage, and then all the healthcare programs, Medicaid and CHIP and the exchanges, they're not coordinated. The amount of money you need to get to earn, to be eligible, differ. The amount of time you need to earn that money differ between those programs. there's no coherence to programs. And one of our policy solutions is to slap on a new program on top of what we already have, rather than to try to make things more coherent. So I will just offer, there are many, many things we could do to suggest and ameliorate the problem. And Gina, I think, began with a very, very good list. Let me just emphasize my two favorite ones. Or three favorite ones. The first is, President Biden is going to have this challenge of the uninsured. Every year since President Trump took over, uninsured rate went up. Now with COVID, the uninsured rate has ballooned even more. We are going to have a problem, and there's just no chance of passing a comprehensive health care bill because, if nothing else, there's just so much to do. So we have to use the existing programs. President Biden's already started making suggestions on that part, expand the open enrollment for exchanges and things. I think we need to remember that 20 million people are eligible for programs, both the insurance exchanges and Medicaid, and yet aren't enrolled. And one of the things we have to do is press very hard on that to get everyone who's eligible enrolled. It makes a huge difference. It actually frees up money for people. Psychologically and mental health wise, people who actually have health insurance have less stress in their life. They can focus on other things, not worry that they're going to be bankrupted. The second one is the proportion of African Americans who have Medicaid is, I think, twice what it is among the white population, maybe even more. Let me just check my numbers. Yeah, it's twice. Medicaid pays a little, and doctors and hospitals are always, trying to avoid Medicaid patients because they say they don't pay enough to. We have to increase what Medicaid pays to get those patients equal treatment. States have done that. Maryland is the best example, where the rate to hospital payment is the same regardless of your insurance. And I think that's a major issue. But here's my favorite intervention policy, which are early childhood interventions. We know one of the most stressful things that lead to disparities is early childhood. And we know that if we intervene early, we can have the biggest impact going forward. Lots of data, lots of studies showing that early childhood interventions between right when a mother gives birth and 1 or 2 makes the biggest difference in terms of being ready for school, not having learning disabilities, not getting involved in the criminal justice system, and then long-term, more earnings and other things. That intervention, I think, has to become mandatory for every child born on Medicaid, integrated into the Medicaid program. And the data suggests that after 5 years, it pays for itself, not only in healthcare, but in all these other, the educational system, the criminal justice system, et cetera. And it seems to me that's not spending, that's government investment in the future. And I think that's where we have to begin thinking about getting rid of the disparities in this country. Let's invest today. It'll pay back in the future. And I think we need more of that mental framework of viewing these things not as spending, we're spending more, but as investments in the future of our country.
That's a really good way to think about that. And it also, your point about the complexity of this, in both bureaucratically, but also in terms of the various causes of some of the inequities that we see, it puts me in your mind of your earlier comment about the hope you have because of the way in which equity is embedded in the various programs and areas of the federal government that Biden is now filling. So that, I think, starts to try to get at the very issue that you're describing right now. In a way that I think has been great. You've really been thinking, you've already started to talk about the issues that I wanted to bring up. So I'm going to ask you to think, have a second opportunity and think a little more deeply about the causes, although you've all raised some of the causes already of the inequities that we see, and they're clearly multiple. But I'm particularly interested policies, whether it's at the university level or at the state level or at the federal level, even if you start, which I think it's fair to do, with the notion that policy development and implementation are well-intentioned, sometimes they don't work the way they were intended. And so I'd like to get a little bit of a sense. You can talk about other aspects of the causes of the inequities that we have, but I'm particularly interested in what is it about the way policies are developed and implemented that make it so hard, other than the fact that these are really hard issues, to address these issues? Is there something even unintentional but systematic about the way policies are developed and implemented that make it difficult to address these issues and sometimes even exacerbate them? And again, you can bring this in any other direction that you'd like, but that's a starting point to think about this. And I'd like to start with Jennifer this time and see, because I know you've thought hard about our policymaking processes. Anything about that or about other issues about the root causes of the inequities we've described that you'd like to talk about or add to?
Yeah, thank you. I wanted to build on what Gina and Benoit had talked about in terms of structural investments. And I wanted to, like Zeke was doing, focusing in his last comment about one particular area, but I wanted to focus on the longitudinal aspect of child development. And particularly wanted to focus on children, adolescents, and young adults, and thinking structurally about how to create the conditions for a whole child approach to developing health and wellness. And building on policy, what's exciting is there's some actually very interesting things going on, and there's been efforts to develop health and wellness in schools and through the school programs. But again, we see the inequities, we see the differences, and we see the disparate impact. So we have local school wellness policies. And these are policies that have been supported through legislation around child nutrition and also around physical activity. And so any school that basically gets funding from the National School Lunch Program or other child nutrition programs has to create local school wellness policies. And there's been, a lot of different work in this area, and there's some really interesting research and studies on it. But I think one of the things that's, so there has to be guidelines in terms of food and beverages and things around nutrition and things around physical activity, et cetera. But I think one of the things that's exciting is there's a conceptual shift that's going on. And this, as Gina was saying, the neighborhoods and the communities to a whole school, whole community, and whole child approach. And so this has multiple different components. It's focused on the physical aspects of our interactions and our education and activity, the nutritional aspects, health education, building health literacy, school, social and emotional school climate, the physical environment, the wellness of the individuals within the school environment, the community involvement, family engagement. And so there's a lot of good conceptual and interesting work being done in terms of policy. But again, the main issue here is that education is highly unequal. What we see is that the racial composition of the highest poverty schools is 80% Black or Hispanic in America. Moreover, we see there are 4 or 5 times differences in access to schools and programs that focus on college preparedness as well as gifted learning between Blacks and whites. We also see that the vast majority of American teachers and principals, 83% indeed, are white. Even though there's studies that show having a Black teacher and a Black principal administrators increases the probability of higher earnings as well as greater job prospects. So the root cause here, I think, is the funding system in America. And the fact that 9 of every $10 spent on elementary and secondary schools comes from non-federal sources. So if we're talking about equity, we're talking about health equity and trying to create standards and across a whole person, whole community model, we need to have a redistribution of resources. And we need to have school districts that are getting an influx of money from the federal government and across the state to more equalize the expenditures. So just a few more statistics, because I think they really do speak volumes. So school districts that have most students of color receive 15% less for every student in state and local funding than school districts that serve the least students of color. And so, these kinds of, and there's studies that also show that just a 20% increase in student funding for poor children leads to another year of education completed, leads to 25% greater earnings, and leads to 20% lower chance of poverty in adulthood. So these are the structural and institutional factors that are both morally problematic and they're economically problematic. And so if we really want to get deep and try to really make some changes, I think those are good places to start.
Thank you. Yeah, excellent points. Risa, I know you have to leave soon. Do you want to any last words before you take off for your,
Sure.
for your other Zoom meeting?
Well, I'll just pick up a little bit on both what Zeke and Jennifer were saying. When we think about how federal policy gets made, it's really disjointed, and as Zeke pointed out, it's siloed, and that leads to programs that aren't necessarily coordinated well with what needs to happen across agencies and across policies, much less at the local level. And so one of the things that I learned watching how the Obama administration approached the problem of childhood obesity, which still does have tremendous disparities in terms of Black and white children and Latinx and white children, is the policy was that every department had to address childhood obesity from their perspective. So education policy needed to address what we're doing in terms of physical activity and curriculum in schools. Agriculture needed to look at SNAP and what we were doing with other feeding programs and on and on and on. And if you have a comprehensive approach at the federal level to enable local policies to be implemented, I think you have a much better chance of getting to where you need to go. And then the other thing that I think is problematic with our policies is we tend to look at them one at a time. And if we were just talking about what makes people healthy, it's all interrelated. It's kind of, Zeke is an oncologist. I think of this as combination chemo or combination policies. You cannot address these complex problems if you're only looking at programs in education or only looking at programs in access to healthcare. It's got to be a comprehensive approach. And I think it has to be engaged at the local level, because when you really get down to it, it's the basics of property taxes, zoning laws, things like that, that really create the environment for what a neighborhood is going to look like. So comprehensive and coordinated at the federal level, and then very local when we actually get to neighborhoods. And with that, I thank you for letting me join you.
Good luck with your next meeting.
Thank you.
Bye-bye. Benoit, what would you like to add to this?
So I've written down combination chemo. I promise to reuse that in another setting. I think that really captures very powerfully what we're trying to accomplish. But what
You're a psychiatrist, not an oncologist.
Hey, it's the brain, so I can totally, I can claim it. I just want to share where my mind wandered when I was listening to all the early childhood interventions and how powerful it is when we are able to instill a sense of hope in children who are able to see themselves in the future, to see a future for themselves, because that will impact the decisions they make in the present, the level of risks they're willing to take because their investment is more or less. There's a seminal paper that was looking at minority children in a high school where they asked them simply to write about their future. There was a very simple instruction. And then social scientists looked at the essays and they did a qualitative analysis, and they saw common themes between minority children and non-minority children. So they talked about, being like an all-star track and field athlete and first boyfriend, girlfriend. But it stopped there for the minority children. The non-minority children went on to talk about family and job, professional successes, and grandchildren. So there were not only qualitative differences in these children's ability to project themselves in the future, but you could also quantify it, and it was a 15 to 20-year difference. So if you're making decisions as a child in the moment, and implicitly that investment is limited or shorter by 15 or 20 years, you're more likely to drink and smoke because it's less of a gamble, because the risk assessment is done differently. And all of the childhood programs that Gina and Zeke have talked about, that's what they will change. They will instill hope. And that's how we get better health outcomes, because of decisions that are made in the present. So I just wanted to share that purely from a psychiatric perspective. It's really powerful, the impact that these programs have on the decisions that children will make.
Yes, thank you. Thank you for that. I get very much the point that you're making there. Zeke, do you want to add to this conversation? Oh, you're muted. You're muted, Zeke.
It is an interesting conversation, and I do think, having early interventions, and again, not, the one I mentioned is just one. If you add on increasing SNAP to pregnant women, so it influences their fetuses, you raise the minimum wage, or give people the earned income tax credit. I mean, these things all individually and collectively have a big impact. And I think if we're thinking about health and trying to use the health lens and get rid of the disparities, it's absolutely essential to try to bring them, we're not going to bring all of them together, but if we could do, Medicaid early childhood interventions, SNAP, so food stamp programs and minimum wage programs, that would have an enormous impact on going forward. Let me just address one other thing, Michael, which I think ties things together, and that's the question of disparities around the vaccine for COVID, which I think is a very interesting example. So in Washington, D.C., they had sign up for vaccines. And one of the consequences is that, as you might expect, people living in upper middle class neighborhoods got much of the early vaccine. So Ward 3 is Cleveland Park, Northwest Washington. It's very well off, multi-million-dollar houses, and disproportionately got almost all the vaccines. So what they've done recently is they release vaccine as they get them, but only certain people living in certain wards and zip codes, which are heavily minority, can actually sign up. So if you live in Ward 3 that has all the rich houses, you can actually get vaccine. You can't sign up. And I think this is actually quite a fair way of trying to remedy the disproportionate allocation of vaccine that Gina so powerfully talked about. Is it going to address everything? Absolutely not, because some of it is access to vaccine, but some of it is also attitudinal, going back to the issues that we've been discussing. Hesitancy for African Americans and Hispanics is very much higher than for whites. And that is only going to be overcome by education and getting people who they can identify with to endorse the vaccine, to take the vaccine themselves, seeing that there aren't problems. And so I think, combined with having them be able to sign up with a communication strategy that acknowledges the hesitancy and addresses it, I think is going to be critical to solving this very, very important problem.
That's a great example of kind of obvious at one level, but creative way to deal with the inequities of who receives it. And ironically, it's one of the few positive outcomes of housing segregation is that you can actually do that because different people live in very different neighborhoods.
Right.
Gina, would you'd like to add something to this conversation?
Yeah, so I have a very simple answer for what is at the root causes of these disparities, and that is racism. We can't forget that is the root cause. And, you know, we make choices on how we are going to spend our money in this country. And we make choices that demonstrate that we still do not value Black lives in the way that we value white lives. And so when you talk about funding for schools, that's a choice we make, the way that we fund our schools. When you talk about Medicaid and the fact that we do not value the life of predominantly Black population, but also of poor people. We don't value the lives of poor people enough to pay as much for their health insurance as we do through the private sector. There's of course many complexities and considerations, but we just have to remember that at the root of this is racism and the value that we place on different lives. I think it's also important to remember that racism is very functional. The example that Zeke gave of who was able to sign up quickly to get that vaccine, that also has to do with racism and who can have the time to be online waiting for like the minute that the vaccine is available. So if we leave everything as the status quo, nothing is going to change. We need to make changes to policies like Zeke shared that will be able to actually change that. I think the other thing is it's tricky because our policies are not explicitly racist. Our policies are colorblind. I'm doing air quotes. You can't see me, but I'm doing air quotes. They're colorblind. But nonetheless, we know that our policies are leading to differential outcomes. So clearly, racism is still happening. And a great example of this, of something that you think would be race neutral, but actually has a disproportionate impact that relates to healthcare, is around prenatal drug testing. And this is actually something I learned about recently from one of my fantastic mentees, Max Tiaco. So ACOG, the American College of Obstetrics and Gynecology, has a recommendation for universal screening for prenatal substance use, because this will help get women into treatment sooner and better outcomes for mom and for baby. However, in 25 states, healthcare providers are required to report pregnant women to Child Protective Services if they have a positive drug test. So, you are influencing the trust that should be built between provider and patient. And what ends up happening is that Black women, despite the fact that Black and white women when pregnant have equal rates of substance use, Black women are reported at almost 5 times the rate as white women. And so you have a policy that is disproportionately impacted on different women. So, again, we have to just always go back to that root of when we're thinking about policies that we think are race neutral, how are they going to impact different people differently because of the systems and structures of racism that we still live in?
Thank you. Thank you for putting that front and center. Gina, those are all really excellent points. I wanted to have our last question before we turn to the audience questions to be, tell me what we should do about all this, but you've all pretty much already hinted at what that is, but also acknowledged that it's a multiplicity of things. So I will give you a chance, maybe starting this time with Gina, who just finished. Is there, if there was a thing that you think should be done most immediately that might begin to address the issue of health and wellness disparities, what might it be? But feel free to say that's an unfair question and we can turn to the audience questions as well. But is there anything else about what we should do collectively, whether it's at Penn, whether it's Philadelphia, whether it's nationally? Is there something that we haven't talked about that you could point to and say, this would be a great start to dealing with this issue? And Gina, I'll start with you.
Yeah, so one of the things that a type of policy that I recently learned about that I'm only learning about, but really love the idea of, is baby bonds. And so we have a massive wealth gap in this country. I think it's something like, the median household wealth for white families is something like $150,000 or $180,000. The median household wealth for Black families is more on the range of like $20,000. So and this is not income we're talking about, we're talking about wealth.
Yep.
So it's a massive gap. The concept of baby bonds really gets at this idea of reparations and really using money to pay back what has been lost over time for Black communities. Basically, the concept is that when a child is born, they get a small investment that continues to grow over time until they're an adult, and then they have that money to support their life and decide what they want to do with that. It's not something that would be just for Black children. It would be for all children whose families make under a certain amount of money or wealth. The details don't matter, but the concept that we would actually just put dollars into the banks of babies, that we allow that to grow, that over a generation, we could close some of that wealth gap. I really like that idea.
That's a great suggestion. I'm old enough to remember when baby bonds were actually a thing. So it's a bringing back of something that was more individualized, but has some pretty deep roots. Benoit, anything you would say, maybe at the level of Penny even?
I do think that the conversations surrounding universal healthcare need to continue. You shouldn't go bankrupt because you get sick. It's not your fault, and you shouldn't get punished. Now, full disclosure, I grew up in Canada, and while I've been here for over 20 years, I had to acclimate to this new reality, and I still don't understand it, to be quite honest. So I do think that looking at healthcare as a priority and as something that is a basic human right is still a conversation that needs to continue. In terms of more Penn-centric policies, we want to make sure that students know that they can access all of the healthcare that they're looking for, and by providing them with many portals, that there's many ways to access the care you need. If you are a student and you have debilitating GI symptoms, and you get to the intersection of 36th and Market, it shouldn't matter if you cross the street north to go to student health to see someone, or if you cross the street west to go to CAPS because you think it's anxiety. You should know that you will achieve the same good outcomes because we work together, because we've undone the silos between physical health and emotional health, and we approach things more holistically. So that would be, it is a policy that we're working very hard to implement, and that's something more on our campus as something to strive for.
Great, thank you, Benoit. Zeke, you've mentioned a number of things, but anything else you'd like to put on the table with what we might be able to do that you would, if you had one policy that you wanted to see implemented?
Well, I already mentioned there's not one policy, but two policies. I do think for the government, these early childhood interventions are the best investment we can make. They're comparatively cheap, $20 billion, if you think that sort of roughly half of all births are on Medicaid. They target people who are excessively stressed, poor people, and I think would be hugely beneficial. And then, the minimum wage, which I do think President Biden is going to address, makes a huge difference to people. Let me just say, again, some of these numbers are just, we're arguing in this country about $15 an hour. If you work a full 40-hour week, every week of the year, and 2 weeks vacation, we're talking $30,000 at $15 an hour. We're not talking about luxury. We're talking about $30,000. To put it in the other way of putting it in context, when the United States was in its, economic heyday, 1968, right? The minimum wage was the equivalent of $22.50. So we're actually going backwards. And we know our economy can tolerate $22.50 because we did in 68 and we were doing fantastic. So it does seem to me we should stop with the crap about 15's too much and just get to 15. It's not luxurious. It's really barely surviving. You're still not middle class unless both parents of a family work at $15 an hour. And it does seem to me that that's the kind of floor that we really need to put for working Americans.
That's a great point. I wish people would use that number that you just put out there, Zeke, because I don't think people realize that that's what that comes out to. I mean, that's pre-tax, and that's if you work if you work a full 40 hours, which most work often you're not even working a full 40 hours. But that's a great point. Thank you for that suggestion, Jennifer.
Thank you. Benoit, I'm glad you mentioned Canada because learning from other countries, I think, is at the top of my list. I wanted to build on what Gina said about racism being the root cause, because I agree with that. My thoughts are that what we really need to do is get even underneath racism and change core values and the norms that we have in society. And because racism is a form of hierarchy. It's a form of domination, and it's a form of oppression. And it's a social system that creates and buttresses social inequality based on race, because it's a system that values white lives and bodies above Black lives and bodies. And that is historically rooted in this country. That hierarchy, it's a hierarchy. It's a form of domination and oppression that has deep roots in slavery in America, and even in the origins of whites dominating Blacks in Africa under colonialism. So, it has global roots as well. Until we start looking at that and trying to change that, and we do need to look to other countries who have not perfect examples, not a formula, not an algorithm, but there are natural experiments all over this world where populations have attempted to figure out what people owe each other in the society, and have come up with some consensus around some core values where there is a greater degree of equity among the people and how people are valued in that society. Now, most of those societies are more homogeneous than our society, no question. But there's some very interesting and I think important examples. And the COVID-19 pandemic around the world, an epidemic within different countries, I think provides a very nice example of what that looks like. So policies that focus on changing values and norms that provide a much more stable foundation for equity, I think is what this country desperately needs.
That's great. Thank you. We've gone longer than I had hoped, but let me just put 3 questions that we got from the many good questions from the audience. So I apologize to the audience, we won't be able to get to them, and you can take a shot at any one of them briefly before we end. One was, and I think this is partly generated by the complexity of the conversation and the fact that we're all acknowledging how interwoven these problems are, is a straightforward, can we do this through the normal policy channels, or do we need something that, in the words of the person who put this in, something more radical? Do we need to think about this from a more dramatic shift if we're really going to address these issues? Number one. Really interesting question that said that building up Black and poorer communities through financial investments and community building sounds great, but is there the possibility, the unintended consequence of gentrification, where a neighborhood gets just good enough for it? And I live in Northern Liberty, so I'm part of the problem, where it becomes well enough off, safe enough, and so on, that then the people who you're aiming the help at wind up not being able to reap the rewards of it. And the last question, which I actually know nothing about, I might even be mispronouncing this, but one question was about apparently an emerging field called fintech or fintech, which is a combination of financing approaches and technology. And do any of you see that, if you know anything about that, any possibilities, hope in that area? So I want to ask you all to comment on all 3, but if one of you would like to take at least a shot at one of those questions, and then we can move on. Anyone want to take on? I saw you nodding, Zeke. Do you know something about the fintech or fintech movement? Is there anything there that's potentially positive?
Yeah, so I think the idea is that you take out the human prejudice and the racism, and you look more at the data. I think the person was saying, it gets rid of the FICO score, which has all sorts of built-in biases into it, and I think this is part and parcel of a series of items, which is to remove race. Remove things that we know are, excuse the word, triggers, like, job applications, get rid of felony convictions and things like that, and really look at, do the people have the skills for the job? There's a whole series of these sort of, you might call them tech-enabled efforts to reduce racism by taking the person characteristics out and letting data work. Whether they, to go to Gina's thing, that I don't think we have an idea as to whether they're going to solve the problem. They may advance some elements. We also need to be careful that they don't undermine and build in biases in the other way. We know that a lot of tech stuff can build in biases
that's right.
in its own way that we only learn about after the fact. So I do think that, again, removing certain bits of information and relying on others probably will help. And whether fintech gets it right, like some of these job application platforms get it right, I think probably going to need a lot of fine tuning, but they do have some hope, certainly, of removing things that have plagued the system in the past. And this is in particular related to access to capital.
That's great. That's great. Thank you for explaining that to me, as well as others, I'm sure, that didn't know. For those of you who have made points or do work more on community building and local development, I thought the question about the unintended consequence of gentrification emerging, do you have anyone want to just say a word or two about that as a potential issue?
Yeah, I'm happy to talk about that. I think it's really important to consider gentrification and the potential displacement of people as we're making neighborhood investments. You could have a whole hour talk on this, but I think 3 important things to consider. One is that you have to work with community members when you are implementing any of these structural changes. And so, only implementing things that are desired by the community and in a way that the community wants it done. The second is that using data to drive where you're targeting. So you don't want to target these interventions to neighborhoods that are like on the cusp of or already in the process of gentrifying, because that will just speed up gentrification. You really want to target them to the areas that are the hardest hit, that are so far from gentrifying that adding these structural improvements will improve health and safety, but is not going to change other people trying to now move in. And then the final thing is side by side when doing these investments is ensuring that that residents are able to stay in their homes and in their neighborhoods. And there's a variety of ways that you could think of doing that on the local level, including tax relief and other things. But I think you certainly need to take all of that into mind, and because the intention for all of these structural investments is not to push people out. I will say, though, that our concerns about gentrification should not stop our making investments into neighborhoods, because then you're just keeping the conditions that are not promoting health. That we have to find a way around that.
That's great. Thank you. That was very explicit and clear. Lastly, are these problems so big that we're not going to be able to solve it with the way we deal with policy issues in the kind of more status quo incremental way? Or another way of thinking it, are you hopeful that if we have the will, that with the new administration, with more attention to these issues at the local level, with Penn's commitment to these issues, that we can actually make a difference in this area, at least enough of a difference that we feel like we're making progress? Or is this something that needs more than just our normal approach to these? And I don't know if there's anyone who wants to take a bite at that.
Well, let me just say, I don't think you have an alternative to normal policy making. You got to get bills through Congress. And so I'm not sure we have an alternative. What I do think, and this I think is something that maybe we can help Congress with, is the actual implementation is something Congress often does not think about when it writes bills. Their job is legislating, not administering or executing, and that's left to the executive branch. And I think that creates a problem. Once they've passed the bill, that's what you hear them. I pass X number of bills, or I pass bills on, and it's not how well did that program go, or how coherent was it with what existed. And I think having a check on that, this is going to be really hard to administer because of the following. It is something that we need more of in the legislative process. Yeah. And I do think one piece of legislation, which is to try to harmonize across social programs, at least the eligibility criteria and the frequency with which people need to renew, to make these programs easy, more one-stop shopping, is a kind of program that could make a big difference in the lives of poor people, and make a huge difference for just the getting the social services they're eligible for, and making it easier to retain them.
That's great. That's a nice, optimistic but pragmatic way to end this. And we're over time, so I apologize to the those in the audience whose questions we couldn't get to, though hopefully we addressed them in some indirect way. I want to encourage audience members to attend our next panel, which will focus on the criminal justice system, first of two on that topic. And that panel will take place on Thursday, February 11th at 5, and we'll be sending out information for registering for that panel. We have another great set of panelists for that panel as well. And then lastly, I'd just like to thank our panelists for what I thought was a really great, informative discussion, and our audience for attending, and ask you all to enjoy the rest of your evening. And I hope to see you at future panels. Thank you very, very much.